You're listening to This Week in Cardiology from theheart.org on Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for February 19th, 2021. This week, COVID, Bernard Lown, type 2 MIs, anticoagulation in COVID-19, and Sacubitril Valsartan. First up, some very brief comments on COVID, and there's more good news. Not only have the cases declined from last week, the slope of the decline has increased too. Plus, millions are receiving highly effective vaccines. We're even seeing observational data on vaccines that look quite similar to the randomized controlled trial study efficacy. Australian scientist Hilda Bastian is the person to follow to stay abreast of vaccine evidence. And at our place, an email came showing that our cases are now down to levels seen in late summer. You really get the sense that we're coming out of the pandemic. My question: given social media and its reward of gloom and doom messaging, the question is, how will society deal with this virus that will so obviously become endemic, as have many other respiratory viruses? What I mean is, for instance, zero COVID is just not going to happen. And even with effective vaccines and degrees of herd immunity, the virus, SARS-CoV-2, is changing. It's like influenza will likely stay with us. And there'll be some infections and death, especially in vulnerable people, for years and years to come. What will happen in the fall or next winter or in 2022? I leave this question for you to ponder because I really don't know the answer. Next topic is Bernard Lown. Now, the renowned cardiologist, inventor, activist, Nobel Peace Prize winner, Dr. Bernard Lown died this week at his home. He was a few months short of 100 years old. I'm going to work on a column celebrating his life, but some brief comments here. Now, there's always a bit of sadness in death, but which young person would not sign up for this story right now? A life of nearly 100 years, 20 years past the average lifespan of a U.S. male. Death in your home rather than the hospital. A marriage of over 60 years. The adulation of colleagues. Discovery of a truly life-saving device, the external defibrillator. A Nobel Peace Prize. But perhaps his greatest achievement, I think, was having a career that was defined by an utterly contrarian view of coronary artery disease, which now has been proven to be correct. He was right. Many millions of dollars have been spent conducting randomized controlled trials of conservative medical management versus interventional care, and the evidence almost exactly corroborates everything Lown thought in the 1980s. Now, in 1981, long before statins, Lown was the senior author of a New England paper in which they described 212 patients who had profound ST segment depression on a stress test. They followed these patients for 5 years and reported an annual incidence of death of only 1.4%. Only 9 of these patients had CABG. They concluded, it was an uncontrolled study, but they concluded that such severe ST segment depression is not associated with a poor prognosis, and there was rarely a need to resort to cardiac surgery. Medical management is highly successful and associated with a low mortality. Now, remember, at the time, 2 of the large CABG versus medicine trials, mortality was not significantly different between CABG and medicines. Look it up if you don't believe me. The VA cooperative and CAS studies. This was even before disease-modifying drugs like statins. Then came the PTCA trials versus medicines like RETA-2. Again, no difference in MI or death. Actually, death rates were higher in the PTCA arm in RETA-2. Then the PCI stent plus meds versus meds alone trials came, like Courage and Berry 2D. And again, intervention did not reduce MIs or death. and most recently, the invasive versus conservative strategies in ischemia trial, no MI or death reduction with intervention. Lown tried to teach us about coronary disease, but we didn't listen. And to this day, I often think of Dr. Lown when I walk by our whiteboard, listing the many names of people getting nuclear stress tests, which will so often lead to cath. And then once there's a cath, there's coronary disease. And once there's coronary disease, this often leads to PCI or CABG. It may indeed take 2 generations to undo this clogged pipe frame of coronary artery disease. A quick personal note. I never met Dr. Lown, but he too changed my career and life trajectory. How? Well, years ago, I got involved in the Lown Institute, and through that I made connections with like-minded people. I know making connections sounds a lot like the jargon term networking, which seems like a small thing, but for me it was life-changing. At Lown, I met Dan Morgan and Andrew Foy, Sanket Dhruva, Rita Redberg. I met Tom Perry from British Columbia, Vinay Prasad eventually, David Brown and David Martin, even Alan Francis in psychiatry. John Unides gave a session on bias in science, and when asked by a family medicine doctor who can be trusted, Unides paused and answered, "Well, there are a lot of independent doctors writing blogs." I tingled with delight when I heard that. From the Lown connections, I learned about evaluating evidence and understanding research, and really, most of the meager academic contributions that I have made trace back to the connections I made through Lown. And I guess that is part of activism, that is building alliances of like-thinking people. The Lown Institute called this group the Right Care Alliance. And again, right care sounds banal, but it is so not banal. It is the essence of good doctoring. Simple things like sitting down next to the patient, listening, removing their fears, and helping patients understand the true nature of atherosclerosis and heart disease. Dr. Lown railed against fearful phrases we hear often, like heart failure, widowmaker, time bomb in your chest, and you failed the stress test. He felt grim scenarios achieved the objective of gaining the patient's compliance without the need for reasoned and time-consuming explanations. More to come on Dr. Lown. Next topic, type 2 MI. Now, Jack has published a large observational study from the MGH group led by Dr. James Januzzi looking at type 1 versus type 2 MI in a nationwide readmissions database. Now, the study was big, included 200,000 patients with type 1 MI and about 37,000 with type 2 MI. Now recall that a type 1 MI is that due to plaque rupture and acute coronary occlusion. It is a highly specific syndrome, and it is usually easy to tell when someone is having a type 1 MI. You often don't even need a troponin. There is chest pain and acute ST changes. A type 2 MI, though, occurs when there is acute myocardial ischemia, but it's due to a mismatch in myocardial oxygen supply and demand. And some examples include coronary artery spasm, microvascular dysfunction, coronary dissection, sustained tachy or bradyarrhythmia, hypotension, hypoxic respiratory failure, or severe anemia. Type 2 MI differs from acute and chronic myocardial injury. In the injury cases, myocyte damage is not due to ischemia, say from post-ablation, or an ICD shock, or acidosis, CKD myocarditis. Now, the main finding of the MGH study is that patients with type 2 MI have a unique cardiovascular phenotype when compared with type 1 MI, and they're managed in a heterogeneous manner. Now, what does all that mean? It means that patients with type 2 MI were older, more often female, had more heart failure, CKD, and AFib. Patients with type 2 MI less often had cath, PCI, and bypass. Patients with type 2 MI had lower risks of in-hospital mortality and readmissions at 30 days when compared with type 1. Now, this is good information because it reiterates the important therapy distinction, namely that in type 1 MI, therapy is to open the artery fast. In type 2 MI, the therapy is most often to correct the underlying cause, which requires doctoring to figure out what the underlying cause is. Now, there is some confusion in that the old distinction of STEMI and non-STEMI, because you can have a STEMI or non-STEMI in both type 1 and type 2 MIs. Let me go slow there. A coronary dissection is not due to plaque rupture and acute thrombosis, but it could present with ST elevation or ST depression. So there is overlap, and at times an urgent angiogram will be needed to sort this out. That's fine. The study findings support an improvement in coding, which should better align with the fourth universal definition of MI. For instance, current coding mandate is to classify ST segment elevation, STEMI, and non-STEMI as a type 1, but that is not really consistent with the universal definition of MI, and I see that's something that ought to be changed. Now, a final comment here. I want to make an announcement that this is a good observational study. I say that because this podcast often laments observational studies, and one could get the impression that this means all observational studies are bad. That is not true. This is a good observational study because it's descriptive. The authors don't make causal inference. And since MI is an inpatient condition, it makes sense to use the nationwide readmissions database. Too often, inpatient databases are used to report on procedures that are done in outpatients. You have to be careful of that. All right, next topic, COVID and early anticoagulation. Now for a bad observational study. The BMJ published a study done on about 4,300 patients admitted early in the pandemic to VA hospitals in the U.S. The main question was whether early initiation of prophylactic anticoagulation compared with no anticoagulation was associated with a decreased risk of death at 30 days among patients admitted to the hospital with COVID. Thus, there were two groups, non-randomized of course. 84% of these patients received prophylactic anticoagulation within 24 hours admission, almost always with sub-Q heparin or enoxaparin. And the second group were the 16% of patients that did not receive early anticoagulation. The 30-day death rates were 14.3% in those who did receive anticoagulation and 18.7% of those who did not. That 4.4% absolute risk reduction translated to a hazard ratio of 0.73 or a 27% reduction in death. The confidence intervals range from 0.66 to 0.81, so a highly significant difference. There were no differences in bleeding. Now, as usually the case with these observational studies, especially those published in big journals, the authors did a lot of statistical adjustments to try to account for the fact that these were not randomized groups. But the main problem with this paper is seen in the Kaplan-Meier curves. Go look at them yourself. They split immediately, and then they do not differ. The difference in mortality is the same on day 3 as it is on day 26. So are you telling me that 2 early doses of subcutaneous prophylactic anticoagulation immediately reduces mortality? No, double no. Of course it does not. Now remember, during the time of this study was done in the pandemic, people were deathly scared of clots in COVID-19. And it is well known that patients sick enough to be hospitalized on an internal medicine service should receive VTE prevention, usually with sub-Q enoxaparin. So a clinician who decided to withhold early anticoagulation had to do it for a reason, and this confounding reason is likely why the curve split immediately. In other words, probably sicker patients did not receive the early anticoagulation. Now here are the 2 sentences in the conclusion. One is fine, one is not fine. The first sentence says, early initiation of anticoagulation compared with no anticoagulation among patients admitted with COVID was associated with a decreased risk of 30-day mortality and no increased risk of serious bleeding. That sentence is fine. But the next sentence, these findings provide strong real-world evidence to support guidelines recommending the use of prophylactic anticoagulation as initial treatment for patients with COVID. No, these findings do not provide any evidence to support anything. They are too confounded, and journals and reviewers should not allow causal statements like this. Finally, I seriously doubt low-dose prophylactic anticoagulation is even worth studying. You want to know if full-dose anticoagulation is effective, and these trials are being done. The preliminary results look to be mixed. More on that later. Final topic today, Sacubitril, Valsartan, and heart failure with preserved ejection fraction. FDA this week has approved an expanded indication for Sacubitril, Valsartan, and it makes it the first drug in the U.S. indicated for chronic heart failure that is not specifically characterized by ejection fraction. I will read slowly the new package insert indication. It says the drug, Sacubitril, Valsartan, indication to reduce the risk of CV death and heart failure hospitalizations in patients with chronic heart failure, period. Benefits are most clearly evident in patients with left ventricular ejection fraction below normal, period. The labeling then goes on to caution, quote, left ventricular ejection fraction is a variable measure, so use clinical judgment in deciding whom to treat. In the package insert, they cite the findings of Paragon heart failure trial, which I've discussed many times, and in short is Sacubitril, Valsartan versus Valsartan in patients with heart failure preserved ejection fraction. Primary endpoint was heart failure hospitalizations and CV death, and remember, the 95% confidence intervals of the relative risk reduction ranged from a 25% reduction to a 1% increase in events. The point estimate was a measly 13% reduction, and the absolute risk reduction was just 1.8%. And I say measly because there was no significant differences in CV death. For CV death, the confidence intervals ranged from a 21% reduction to a 16% increase. The hazard ratio was 0.95, clearly no signal. The benefit in the primary endpoint was driven only by heart failure hospitalizations. Now, the FDA Advisory Committee was persuaded by two observations. One was the subgroup finding in Paragon, where the reduction in the primary endpoint in patients with EF less than 50% was significantly greater. They were also persuaded by a meta-analysis which combined Paradigm, which was Sacubitril, Valsartan versus enalapril in heart failure with reduced ejection fraction, and Paragon. And this analysis found a graded benefit of the drug based on ejection fraction. But of course, both these points are problematic because subgroup findings in trials that have non-significant primary endpoints are very susceptible to bias and chance. And B, combining two trials is dodgy because one had a medium dose enalapril as a comparator and the other had Valsartan as a comparator. So it's really hard to mix these trials. Now, the things I like about this new FDA announcement is that it is vague. Doctors will have to use judgment, and that is good. In a perfect world, you would hope this happens all the time. I mean, let's say you have a woman with an ejection fraction of 40% and highest blood pressure who is struggling with chronic heart failure. Sacubitril, Valsartan might be more beneficial than Valsartan alone. The problem, and the reason I don't like the new indication, is my choice just now of the term might be beneficial. U.S. healthcare is super expensive. This drug will add lots more cost to an already unjust and unequal healthcare system. My argument, therefore, would have been to force another trial. Let the sponsors pick the subgroup of heart failure patients they think the drug will work on. If it shows benefit, then we can readily adopt it with the knowledge that we know it works. Now, that trial is never going to be done. I mean, look at the SGLT2 inhibitor class, for instance. There are almost too many trials to count. Given the number of trials in this drug class, we are very certain that this drug provides benefits. So that's it for this week in cardiology. As always, I am grateful that you listen. Thank you. And remember, friends, if you like this podcast, it really helps to give us a rating and or write a few sentence review. That way others can find us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.